Yeah. So thank you. So good afternoon to one and all, dear sir and ma'am. So on behalf of API Vellore branch, it's very immense pleasure to start this PG Masterclass presentation. So from CMC Medicine Department, Dr. Akash Michael is going to present a clinical approach to a patient with the cervical myelopathy. So over to you, Dr. Ramya ma'am, to proceed for the further discussion along with the medicine department and the specialty department, ma'am.
Good afternoon. Thank you, Dr. Anita, for that. 1 minute, sorry. Today we have two discussants. One, Dr. Saumya, who's a professor of medicine, and she's also the Human Resource Director in CMC Vellore. And second discussant is Dr. A.T. Prabhakar. He's a neurologist, he's a philosopher, and he's currently working on the domains of cognition. He has developed many scores which are very easily usable for cognitive domains. So both of them will be discussing a neurology patient with a neurological problem. And the presenter will be Dr. Akash Kumar Michael, and he's a final year postgraduate. Thank you.
Thank you, Dr. Ramya. And yeah, we hand over to Akash. Welcome, Prabhakar, and welcome to the entire online team.
Good morning, ma'am. Good morning, ma'am, and good morning, sir. Myself, Dr. K. Akash Kumar. I'm junior resident from Department of General Medicine, Christian Medical College, Vellore. Today, I'm going to present a CNS case in API-PG Master Class Clinics. So let's go into the case. Mr. C, he's a 25 years old gentleman from Jharkhand. He's a police trainee. Informant is self and reliability being good. He presented with chief complaints of inability to lift bilateral lower limbs and inability to perceive sensation below the level of chest. History of presenting illness. He was undergoing training as a trainee at the police camp and appeared to be in good health since 2 weeks ago. In the camp, when he did high jump, he stumbled and fell down and sustained injury to his neck. Immediately post fall, he had severe pain with shock-like sensation over his upper back and also noted difficulty in moving his bilateral lower limbs. He noted that he was not able to flex or extend his ankles and was not able to get up and felt difficulty in turning sideways when attempted. He was able to lift his both arms above head while being on ground, but noted difficulty. Sorry.
I think go ahead, Akash. I think somebody had their mic on. Please go ahead.
But noted difficulty in grasping things nearby, which was more on right hand than on left. He was able to raise his head off ground and did not have any breathing difficulty. He also reported severe pain over his upper back and was unable to perceive the cloth sensation below the level of chest. He was able to perceive sensation over his bilateral shoulders, arms, forearms, and all fingers. But when he tried to grasp nearby objects, he was able to feel the object, but reported decrease in sensation over his medial aspect of bilateral forearms and arms. When he attempted to raise his head off ground, he is able to feel the back of scalp and upper neck in the ground. He did not have any history of double vision or blurring of vision. He did not have any difficulty in moving eyeballs in all directions, and there was no drooping of eyelids. He was able to close and open his mouth and was able to perceive sensation over his face. He did not have any slurring of speech or drooling of saliva while eating or drinking. He did not report any hard of hearing and was able to swallow foods with difficulty. He did not have any nasal regurgitation and there was no difficulty in turning head side to side. He was able to shrug his shoulders and was able to make food bolus and manipulate food. He was able to perceive bladder fullness and did not report any dribbling of urine. He was not able to perceive the sensation of catheterization when he sought medical attention and did not have any sensation in the perineum when he was prepped for catheterization. He also noted that he had passed stools without his knowledge. So there was no clockwise or sequential involvement of motor weakness. There is no history of involuntary muscle contractions. There is no history of external injuries to head. There is no history of bleeding or discharge from nose or ear. There was no history of speech disturbances. and there was no history of loss of consciousness, seizures, headache, or vomiting. Going to past history, there was no history of diabetes mellitus, systemic hypertension, thyroid disorder, or a chronic kidney disease. There was no history of malignancy in the family. There was no history of similar illness in the past. Treatment history: with the above complaints, he was taken to nearby hospital where he was catheterized and was given conservative management. He did not have any addictions. So summarizing, he is a 25 years old gentleman, Mr. C, had nil known comorbidities, had presented with chief complaints of acute onset weakness of bilateral, proximal and distal lower limbs, truncal weakness, and weakness of bilateral hands with defined loss of sensation of all modalities below the level of chest, and also reported decreased sensation over the medial aspect of arm and forearm with bowel and bladder involvement, and no cranial nerve abnormalities after a history of fall with time of onset to maximum weakness within a minute. So in this case, he had both sensory and defined, has a defined sensory level, motor level, and also has a bladder involvement. So my localization will be to the spinal cord, especially to the lower cervical cord. Going to examination. So he is a moderately built gentleman. He is conscious and oriented during examination. He did not have any pallor, icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy. All his peripheral pulses were palpable, and his head-neck ratio was 13, and he had a grade 1 bed sore over his gluteal fold. Vitals: his blood pressure is 110/70 mmHg, measured in right upper limb and supine position. His respiratory rate is 19 per minute, and his heart rate is 84 beats per minute and is regular. Going to higher mental function, he is a right-handed gentleman. He is conscious and oriented to time, place, and person during examination. His immediate memory, reason, and remote memory was intact. Comprehension, fluency, and repetition was normal, and had a normal attention span. Cranial nerve examination. Going to olfactory nerve, he was able to perceive smell normally bilaterally. Optic nerve, he had normal visual acuity and had normal full range of visual field of vision in right and left eye. Color vision is normal in both eyes, and fundus, there is no papilledema in both eyes. Going to third, fourth, and sixth nerve, he had full range of extraocular movements, and there is no ptosis. Direct right reflex is present in both left and right eye, and accommodation reflex also present in left and right eye. Going to fifth nerve, sensation over the face is normal bilaterally. He is able to clench teeth. Corneal reflex is present bilaterally, and jaw jerk was absent. Facial nerve, he was able to wrinkle forehead. There was no deviation of angle of mouth. Was able to blow cheeks and hold air in mouth, and was able to close his eyes against resistance. Vestibulocochlear nerve, Rene's test, air conduction is better than bone conduction, and there was no lateralization bilaterally in Weber's test. Next is 9th and 10th nerve, position of uvula is in midline, gag reflex is present bilaterally. Spinal accessory nerve, he was able to struck shoulders against resistance, and was able to turn his head against resistance, and there was no deviation of angle of tongue on protrusion, and the power of the tongue is being normal. Next is motor system examination, bulk. The upper limb arm, the bulk was 23 centimeters and the left being 24 centimeters. And in the forearm, it is 21 centimeters in the right and the left forearm being 21 centimeters. And thigh, right thigh, it is 46 centimeters and the left is 47 centimeters. And the calf being 26 centimeters and 27 centimeters. Tone, he had normal tone in the right upper and left upper limb. What in the lower limb, he had bilateral hypotonia in the right and left lower limb. Power, going to muscle groups, he had abduction, it is normal, it is 5/5, the right upper and lower, in the right and left shoulder. And adduction, it is 5/5, and flexion, it is 5/5, right side and left side. And extension, it is 4/5 in the right side and 4/5 in the left side. Elbow, biceps, it is 5/5 and 5/5 in the right and left side. Brachioradialis, it is 5/5 and 5/5 in the left and right side. Triceps is also 5/5 and 5/5 in the right and left hand. And wrist, flexor carpi radialis, it is 4/5 in the right hand and 5/5 in the left hand. Extensor carpi radialis longus, it is 4/5 in the right hand and 4/5 in the left hand. Finger, Flexor digitorum profundus, it is 3 bar 5, and it is in the left, it is decreased also with 3 bar 5. And finger adductors, he has difficulty in finger adduction with the power noted being 3 bar 5 in the right hand, and it is also 3 bar 5 in the left hand. Next is going to leg muscles, hip flexion, extension, adduction, and abduction. It is 0 bar 5 in the right hip, and it is going to the knee, flexion and extension, it is 0 bar 5 in the right and left side. Ankle, plantar flexion, dorsiflexion, inversion and eversion, it is 0 bar 5 in the right and left ankle. Going to toes, big toe extension, extensor digitorum longus and flexor digitorum longus, it is 0 bar 5 in the right and left toes. Reflex, going to superficial reflex, corneal reflex, it is present in right and left eye. Conjunctival reflex is present normally in right and left eye. Gag reflex is present. Abdominal reflex is absent. Cremasteric reflex is also absent bilaterally, and plantar reflexes were mute during examination. Going to deep reflexes, jaw jerk was absent. Biceps, it is 2 plus. It is present in the right and it is 2 plus in the left side. Triceps, it is also 2 plus in the right side and it is 2 plus in the left side. Supinator, it is present with 1 plus in the right side and 1 plus in the left side. His finger jerk was absent both right and left side. Knee jerk is present in right side and left side, and the ankle jerk is present with 1 plus in right side and left side. Sensory system, fine touch, pain and temperature, crude touch. He had decreased, it is decreased along C8 and T1 dermatome, and there was no perceived sensation below T1 level. Going to vibration, upper limb, it is preserved at level of shoulder joint, elbow joint, wrist joint and distal phalanx, whereas at lower level, it is absent at the level of ASIS, tibial tuberosity, medial malleolus and distal phalanx of great toe. Going to vertebral level, his vibration sense is preserved up to the level of C7. Position sense, upper limb, preserved at interphalangeal joint of middle finger, metacarpophalangeal joint, wrist and elbow joints. In lower limb, it is impaired at interphalangeal joint of big toe, ankle and knee joint. Perianal sensation is absent. There is no voluntary anal contraction and bulbocavernous reflex is also absent. Cerebellum, he doesn't have any dysarthria. There was no dysdiadokinesia. He is able to perform finger nose test. There was no downbeating nystagmus. There is no intestinal tremors and has rebound phenomena is present. He doesn't have any meningeal signs, Kernick's and Brudzinski sign being negative. Gait was not able to assess. Spine and cranium normal, and there was no local tenderness, no gibbous or deformity noted. Other system examination, respiratory system, he had normal vesicular breath sounds heard normally, and there is no adventitious breath sounds. Cardiovascular system, S1, S2 heard normally, and there is no murmurs. Perabdomen soft and no organomegaly, and bowel sounds present. So diagnosis, so in this case, this gentleman, he had an acute onset and had a defined level of motor sensory involvement and reflex level. So I would, my diagnosis will be, he had a traumatic compressive cervical myelopathy with the vertical level being the maximal reflex level. He had sensory of C7 because he alleged there is a decreased sensation over the medial aspect of forearm and arm. Motor, the maximum motor level is C7, and he said there is a decrease in weakness in the finger abduction and finger flexion. Reflex level, the maximum reflex level I got is C7 in the upper limb, and C8 it was absent, finger jerk was absent. So I would say the probable lesion will be in the C7 or C8 level, or C8 or T1 level, localizing to C6, C7 or C7, T1 vertebra. And the horizontal level, you have loss of sensation of all modalities, so it will be a hollow cord syndrome.
Thanks, Akash. I think Prabhakar and I will just take turns asking questions, and we invite everybody in the audience also to ask questions as we go along. There are a few things that you've been clear in your localization and the approach, so well presented. I think you have mentioned most of the things in your history and examination that we would expect. I'd just like you to go back to your history And just to clarify that, when in time has he come to hospital? Like, you have seen him after how long of the actual event?
Ma'am, he presented to us after 2 weeks,
2
ma'am.
weeks. 2
So
weeks ago.
initially he was hospitalized elsewhere for 2 weeks, and from there actually he came to us for another medical condition.
So if you look over the 2 weeks to presently, is he exactly the same, or has anything changed?
No,
As
miss,
in, what is
exactly
his
the same.
present thing over 2 weeks?
Currently, the neurological deficit hasn't worsened, ma'am, since the onset and till our presentation and the current presentation also till date. Yeah, there is no worsening of further neurological deficits, and it has been stable.
Sure. Historically, if you wanted to tell us whether it was what type of lesion it is, UMN versus LMN, I think that's something that maybe you could clarify. I'm not sure whether you told us in your history. In your history, how do you differentiate between that? This is of course, a basic MBBS question. Uh,
Um,
just next, you told us what he's able to do and not able to do. But in the description of the motor power, how would you decide whether it was upper motor or lower motor?
so when he said, so the presentation he had flaccid weakness, ma'am, on presentation, and
Yeah. How would you get that
so
historically? This is
so
history versus UMN versus element, not a difficult question. How would the patient give you history when he was going to talk about what type of weakness it is? I know what it is on examination. You have examined the patient. Historically, how would you differentiate between UMN and element?
he said his legs were flabby, ma'am, during presentation,
Sure.
and
What
uh,
else? I'm just trying to translate UMN versus element into a clinical question. That's all. So while you think about that, that is just to give us an idea of how his presentation is at the beginning. You've told all of the others. There was one, just go later in your history, you also gave in your negative history. Just go the next 2 slides, please. The next slide again. Okay, then here you have said something about the bladder. What type of bladder do you think this is? I know you've come to your final diagnosis. How do you differentiate between the various types of bladder
if it's
historically?
if it's an human bladder, so he would have got a spastic bladder, ma'am. So, but in this gentleman, so if it's an element bladder, ideally they will have a neurogenic bladder. They will have a overflow incontinence. The history will be like the patient will have a overflow incontinence.
Sure.
But in case of an human bladder, there will be a spastic bladder.
What will you call this for him? What do you think it is?
Um, so for him, actually, there was no dribbling of urine, ma'am, historically, and was catheterized immediately within 2 hours. So not
So
able to clearly differentiate at that time.
yeah, you're right in that. So because he was immediately catheterized, he was in a situation in his work where it immediately took him for care. You may not be able to differentiate between that. Just one more question, and then I'll hand over to Dr. Prabhakar for a bit. You said there was no clockwise or sequential involvement of water weakness. What did you mean? What were you looking for? Is there a phenomenon that we look when we look at this? When is it caused? What did you mean by this history? Yeah.
So I would, when I thought of specifically of foramen magnum syndromes from upper cord, so they will
Sure.
have this cruciate hemiparesis and Ellsberg phenomenon.
Sure.
So
What is Ellsberg phenomenon?
Ellsberg phenomenon, there will be usually an clockwise or sequential involvement of, there will be involvement of motor weakness. There will be, because of the somatotrophic organization of the fibers, ma'am. So it can start at any arm, but there will be maybe an ipsilateral arm and starts by went to the ipsilateral leg, followed by contralateral leg and contralateral arm, or it can be other way out. So it can start with any arm. So it can be, we'll be able to localize either it's somewhere else the lesion is higher up, either it's in the foramen magnum or upper cervical cord or spinal cord we can think of.
Sure. And usually, which kind of pathologies cause this? Which etiologies are more likely to cause an Ellsberg phenomenon?
Usually will not be an acute presentation. It will be an spinal cord tumors.
Yes.
All those can have this sequential involvement.
Sequential. Prabhakar, please go ahead. This is just
Yes,
a few questions.
So Akash, we'll just go back to the same point in history. So How would you generally, not in this case, differentiate between LMN and UMN weakness? Of course, here everything happened too rapidly, and in the acute setting, there'll always be flaccidity, so you can't go by flaccidity. But what are the points in the acute setting that will help you tell between UMN and LMN? And generally, in a chronic setting, what all will tell you?
We can ask any history of fasciculations and
Okay.
muscle atrophy in case of elements in chronic settings. And in acute setting, mainly they will have noted hypotonia and the
So in the
lower
acute setting, you can go only by the pattern of weakness. So you can't, there'll always be, like in this case, there's a spinal shock or even a stroke, there may be a neuronal shock. So the tone may not be a indicator, but the pattern. So if you get hemiparesis, if you get a paraplegia or a quadriplegia with a level, that would tell you that you may be dealing with a UMN lesion. So the pattern of involvement. On the other hand, if you get a mononeuropathy like a wrist drop or a foot drop, or if you get only proximal, so the pattern will tell you. So in the chronic setting, how to differentiate between UMN and LMN? Historically. So one, you said LMN would be proximal more than distal. So it could be symmetrical or asymmetrical depending on the cause of it. But one thing to say is if there's thinning of muscles or if there's twitching of muscles, because these are things that you would say in history, not fasciculation. So if twitching is there, thinning is there, proximal more than distal, and then you would think of more of a LMN. So UMN, what will you specifically ask for? So early signs of spasticity, one would be like chronic progressive lesion. They'll have difficulty in putting their legs over the motorbike. That's equivalent to an adductor catch. So tripping over, because spasticity is dynamic, you will find that patients tell you that they're tripping over small objects when they're walking. And in the night, there may be history of flexor spasms. So presence of tripping while walking, adductor catch on history, and presence of probably tripping will tell you that you're dealing with a UMN lesion. So here, one thing that you could get history for, in now that you're seeing him 2 weeks, if he starts getting spasticity, you may find that he'll start having flexor spasms in the night. Yeah. Over to ma'am. Ma'am,
Yeah, please.
yeah, we can go on.
Yeah,
Dr.
anybody else?
Akash?
Yeah, please.
Dr. Akash?
yes, ma'am.
So clinically, how will you differentiate from intramedullary and extramedullary compressed lesion?
Ma'am, intramedullary lesion, so clinically, they will have sacral sparing, ma'am, and extramedullary there can be an asymmetrical presentation, and they can have a radicular pain, and sacral bowel and bladder involvement earlier. Bowel and bladder involvement will be earlier, but in case of intramedullary, usually they will have a funicular pain rather than a radicular pain, and they will have this especially of sacral sparing, so, which will happen later at time.
So bowel and bladder pattern in intramedullary, extramedullary, where it will be earlier, where it will be late?
Intramedullary, it will be late, ma'am.
Late. Where is the fibers of bowel bladder in horizontal level, spinal cord?
It will be at the lateral aspect of.
Okay, usually in intramedullary there is an early bowel and bladder, right? An extramedullary is a late presentation. Okay, so in your case, you told that the presentation is after the 2 weeks, huh? So before admission to the hospital. So in the initial first 2 weeks, how is the bowel and bladder? Because after admission it was catheterized. Before admission, how is the pattern?
Before admission, he was catheterized within 2 hours, ma'am. So regarding the bladder, so we are not sure of, ma'am. So bowel, so currently he has early bowel involvement. He was not able to feel the that he was passing stools, and his bowel and voluntary anal contraction on all those were absent.
Okay, did you done any PR for this patient, rectal examination?
Yes, ma'am.
So how was the tone, final tone?
Tone is lax, ma'am.
Lax. So your meaning is LMN. No?
ഇതൊന്ന് നേരെ വെക്കണം. കാലിൽ ചെറിയൊരു മുറിവ്.
Okay, okay.
Basic.
So maybe we can.
Yeah. Sure. Thank you, Dr. Anita. Is there any other questions from history from the audience that anybody would like to ask? This is a discussion with all of us contributing to the teaching. If there are any other questions, please put up your hand and we can ask for the questions. We can ask later also. Any questions can be put in the chat if anybody
Hello?
wishes to ask.
Hello.
Yes, we can hear you.
Can you hear me?
Yes, sir.
Yeah, I'm Dr. Krishna Kumar from Cochin, Professor of Medicine.
Please, sir. Please go ahead.
Yeah, because it's I've got a little connectivity issue. Can I ask
Sure.
a few questions together to Akash?
Sure. No problem, sir.
Yeah.
Please go ahead.
Yeah, please, Akash, can you answer me if you
Yes,
don't
sir.
mind?
Yes, sir.
Yeah.
Yes, sir.
You said corneal reflex and in the superficial reflexes. Are you right in that?
Sorry, sir.
Is corneal reflex part of the superficial reflexes, or is it a cranial nerve phenomenon? We are talking about motor system, and you're talking about superficial reflexes, but then corneal reflex will not come in that.
Okay, sir.
Okay, it's not a superficial reflex, it's an exclusive reflex for a particular cranial nerve. So please don't add that there. I mean, randomly, I'm just remembering, I have not written down anything. In fact, I'm outside my house, so I'm not getting the connectivity as well, but I would like to point out a few points. Yes, if the patient was having hypotonia immediately after the fall, what is your impression?
Likely consider the patient is in spinal shock, sir.
Can you briefly, in 1 or 2 sentences, tell the mechanism of spinal shock? How it happens, why there is spinal shock? 1 or 2 sentences, not in detail. There are chapters written on this topic, but then if you don't, then you please pass on so that I can move on fast.
No, sir. I don't know, sir.
You don't know. Did you examine this patient's optic fundus?
Yes, sir.
What is the importance?
Papilledema, sir.
Why?
Because in case of upper cervical cord lesion, if there is any cord compression, they can have a
How?
API-ICP and
How?
foramen magnum syndrome.
Upper cervical, how papilledema can occur? In fact, any spinal cord lesion, can it lead to papilledema?
No, sir.
Please say if you don't know so that we may
No, sir.
communicate. Have you heard of Freund syndrome? What is Freund syndrome?
Sir. I don't know.
Okay. Did you mention about the spinal cord examination?
Yes, sir.
Did you examine the spinal cord externally?
Yes, sir. Yes.
How did you palpate the spinal cord? What was the technique used? Can you just tell us now that we are not in the same room? Which finger did you use?
I use my thumb finger,
Huh?
sir. I use my thumb.
Thumb. Never use the thumb. If there's something shaking there, you are pressing it. You have to use a fist. You should learn this from the orthopedic surgeons. Just say use the fist and give a gentle tap on a flat basis. Never use your thumb. You are going to make it worse.
Okay, sir.
Okay. Yes. Did you mention about any neurocutaneous markers, by the way?
No, sir.
This
I
is
haven't.
post-traumatic, I know, all of a sudden. But did you mention about the neurocutaneous markers?
No, sir. I haven't.
You haven't. It's mandatory in all neuro cases, even though this is obviously post-traumatic. But it's a routine to mention. Can you name some neurocutaneous markers? Common.
Neurofibromas, cephalospot, and
That's all.
adenoma sebaceum.
Anything else? Okay, that much you know. Please read. There are more than 12, at least, that I know. There'll be more. Okay. And in the history, it's mandatory these days to mention whatever it is to mention. I mean, there is a system in India to mention past history of tuberculosis as routine. And of course, it's more important in Tamil Nadu even now. And did you mention about COVID past history? Not at all related directly, but it's mandatory or it's better that you mention about history of COVID in any of your patients as a routine past history. In the 60s and 70s, we used to say that if you know syphilis, you know half of medicine. In the 90s, we used to say that if you know HIV, you know half of medicine. Now we say that if you know COVID, you know half of medicine. You know what I mean? Post-COVID and all those. Post-vaccination is different. So I suggest humbly that you mention about COVID history in any of your patients in a long case when you present as a final year PG. Clear?
Yes, sir. Yes, sir.
Yeah, this is all which comes randomly to me. I had mentally noted down many more, but then I'm actually traveling. I'm not getting the mobile range continuously. Please carry on. That's all from me now. Let's see.
Thank you so much,
Thanks.
Dr. Krishna. I think we were laying stress on things that we have to routinely say when we have to examine in when presenting a neurological case, especially at a postgraduate level. There's certain checklists that you were mentioning, and you have picked up on very valid points within the history and examination, which Akash will need to, will need to kind of pay attention to and not make a mistake. So having said that, since Sir mentioned the corneal reflex and we are in examination, Akash, can you tell us, as Sir rightfully pointed out, what would the afferent and efferent be of the corneal reflex? And we know that it's sitting wrong in the superficial reflex side. It
Yes.
should have gone off into
Afferent
your
will be
exam.
fifth nerve, ma'am, and
Yes.
efferent will be seventh nerve.
Okay, sure. So you know where to place it
Akash,
now.
in a
Sir, yes, sir.
cervical spinal cord lesion, which cranial nerve are you interested the most?
Sir, I will think of especially the lower cranial nerve, sir.
Lower
9, 10.
cranial nerves, cervical spine lesion. Which cranial nerve? What is balaclava helmet pattern of sensory loss? Which
Fifth,
cranial nerve?
fifth cranial nerve.
Ah, yes. Why?
So because trigeminal nerve, the nerve fibers
Yes.
arranged in a
Not
uh,
nerve fibers. Trigeminal nerve nucleus
Hmm.
has an elongated part which extends up to which cervical spine? Which level? I'll give you option. This is an era of options. C1, C2, C3, C4, C5. Pick up.
C3, C4, sir.
No, you're wrong. Options always are dangerous. Yes. So you have to read all these, please. Because fifth cranial nerve can be involved in high cervical cord lesions. Lower cranial nerves, of course, only if the lesion is still above, which you are not considering here. Okay?
Okay, sir.
Yes.
Thank you, Dr. Krishna.
What
Valuable
is
insights.
Gaggenhalten, Akash?
Sorry, sir.
It's pronounced in many ways. As South Indians, we may pronounce Gaggenhalten. I don't know how it's pronounced properly, but the thing is the same. Have you heard about this word, Gaggenhalten?
Yes, sir. It is.
Yeah, but you're not too confident, I think. We can pass on. That's why I'm asking. If you don't
Yes.
know, please say, I'm not sure now.
Not sure, sir.
Okay, good. No problem.
Hmm.
No problem. Which neurocutaneous marker is seen in the optic fundus? What is choroid tubercle?
No, sir. I'm not sure.
I'm not sure. No problem. This is all for reading. You know, this process of reading. I was so excited to listen to your presentation. You presented well in a systematic way. So it's a good beginning. But I think you have how many months more for your exam? Final.
6 or 7 months.
Yeah, enough, more than enough. Please note down these and you can probably look into. But what is Brown Sequard? Not at all related directly to this, but then it is part of spinal cord.
Hemicord syndrome, sir.
Yes. Can you just tell in two sentences what exactly is the abnormality?
So they will have this ipsilateral same level below. They will have weakness, and they will have ipsilateral vibration sense, position sense will be lost, and
Yeah.
contralateral 2
Yeah,
levels.
yeah, 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 yeah. You know, I mean, for want of time, I'm going to the next question. As part of spinal cord examination, I mean, neurological examination, we are always supposed to do the signs of meningeal irritation. Did you do that in this?
Yes, sir, I have.
You have done? You have done a big mistake. In a spinal cord injury patient, did you flex the neck? Did you flex the neck to look for neck stiffness? It's unwarranted. Not only unwarranted, it's dangerous. Never do that. This is how we people catch some of these, neuro cases. Never do that. Don't say yes, I did. Huh?
Yes.
You cannot. You should not flex the neck in such patients. You know why? The quadriparesis can worsen naturally. Yes, good. Can you tell us some common diseases seen in police constables? Apart from policeman's stiff hand, maybe. Not neurological, in general, please. You know the life of a police constable in Vellore. Just think about that. It's okay. It's a by the way question. Doesn't matter. You're presenting well, but probably you need to read up some of these standard. No, I've been examiner for more than 20 years for MD. So we all ask this and we all hear the same questions from other examiners. Unfortunately, I didn't get a chance to come to Vellore so far. Maybe one of these days. So these are standard questions.
Yes,
These
sir.
are standard. And please don't mention bed sore. The better term will be pressure sore. Because the sore is not on the bed, but on the patient, right?
Yes, sir. Yeah.
Yeah, pressure sore is a better term.
Yes, sir.
These are all, by the way, corrections. It is not life and death. But if you flex the neck in a cervical completion patient, some of the, especially the older Tamil Nadu professors, can finish you. Not now, not now. Don't worry. Thiruvengadam sir and all those people. But because that's really dangerous, right?
Yes, sir.
Did you really do that? No. Thank you. And this, you said the power is some plus. What plus is that? 2 plus.
Sorry, sir.
Just go to your power
You-
slide. Sir is
The
asking
power,
questions on the power.
how much was it? Some plus you told. 2 plus, 4 plus, something. I know it's okay. What was the number? It doesn't matter. You said some plus, right? 2 plus, 4 plus.
That is reflex, I told, sir.
Huh?
That's reflex for reflex, I told, sir. Power, I
And
said 5.
power?
5
You
bar
said 5 on 5 everywhere, right?
5 and 3 bar 5 in the finger, abductors, and
Okay. Then it's okay. I thought you talked about the plus in the power. Please don't do that. That is only the plus for power is used only if you are continuously examining the patient. For example, yesterday 3 and today you are examining again. If it's slightly better than 3, you may use 3 plus. Slightly worse than 3, you may say 2 plus. But don't say that plus if you are examining only once. Just a point to correct. Just a small point to correct. Did you examine the other parts of the body because he fell down and any other injuries?
Yes, sir.
Did you palpate the scalp?
Yes, sir. As far
Yeah.
as I take, there is no
Yeah.
external injuries.
Now that your patient is inside the ward in your hospital, tomorrow when you go, he has deteriorated. What can be the reason now, after so many days? Deterioration, acute sudden deterioration in an established case of quadriparesis. Sudden deterioration.
In case of,
Don't tell that he fell from the cot. It
maybe
doesn't happen in CMC.
he had
The nursing care is fantastic.
any vascular impingement
Like
or
what?
blood vessel got ruptured. So,
Can you be a little more specific? Vascular is correct, but not exactly blood vessel. Please read up. Please read up. Now, tomorrow when you go for rounds, he's asking that, can I take bath? What is your advice? With the help of somebody, of course.
if the neck is stabilized, it's
Uh-huh.
stabilized.
Is there a collar there in this patient when you examined?
Yes, sir.
What kind of collar? Soft or hard? Which is better?
Hard collar, sir.
Hard collar. Why? Where do you use soft collar? In which situation? There's a role for soft collar also. Hard collar, you may be right. But then, where do you use soft collar?
Case of any degenerative,
Huh?
in case of any spondylosis,
You give spondylosis a collar even now in 2025. It helps only to lead to atrophy of the paraspinal muscles. There's no role for collar in spondylosis. Please remember. Two myths about spondylosis have been busted at least 10 years back. One, cervical spondylosis is not a cause for vertigo. Never a cause for vertigo. Number one. Number two, collar doesn't help, it harms by leading to atrophy of the paraspinal muscles. Please remember this. No collar should be used in cervical spondylosis.
yes, sir, understood.
That is gone. We have seen, we have used, we have done all these, but now no collar. Okay. Thank you. There are a lot of things, but then it shouldn't be a monologue. Thank you, madam, for giving me this chance. If there are any more discussions, I'm happy to listen to.
Sure. Thank you so much, Dr. Krishna, and we will be sure to invite you also. And you have been complimentary to our nurses. I'll pass on the information. So thank you for all those questions. As you said, in your experience, examiners will ask certain questions and some things have to be said correctly.
Thank you, madam.
And it's sometimes in the exam versus real life, we need to pay attention to little details.
Yeah. There are some
That's-
standard exam questions and there are some trap questions always.
So thank you, sir.
Thank you. Thanks a lot,
Thank you so
madam.
much. Thank you, sir. So we were talking about a few more things to just ask. One we had talked in the history. You also on examination, you're a general exam, Akash. If you can just go to your general examination, Akash. We had said, yeah. So when you look at head and neck ratio, why would you look for it? Like what were you trying to tell us when you said head and neck ratio was 30?
Any case, the head neck ratio is greater than 13.6, ma'am. We can think of it as short neck. We can think of any already had a predisposing factor like has a cranium in any CV junction abnormalities. So all those things can be thought of, ma'am.
Sure. And as Dr. Krishna mentioned, the bed sore is, maybe a different terminology can be used. I think please go ahead to the next slide of your examination. And yeah, this higher mantle and cranial nerves you can skip by. Please go ahead.
Ma'am, one
Yes,
question.
please. Dr. Anita, please go ahead.
Yes. Dr. Akash, for this is a clear-cut traumatic. Did you check the height neck ratio?
Sorry,
Because already you said is in the collar, neck collar.
yes, ma'am, I did. So actually, when I was checking his vertebral level for examination at that time, I checked.
So as such, sir discussed previously, right? So the neck movements. Be cautious while checking if needed, because it's a clear-cut history of trauma. So I think so. It's not manipulated, or you can tell that because of this traumatic lesion, the patient's already on neck collar. So I couldn't able to examine the height neck ratio. That
Yes,
you can write in for fair purpose. Thank you.
Sure, ma'am.
And then as rightfully papilledema and Freund syndrome, something that Dr. Krishna specified on. And the corneal reflex, you had put it here and unfortunately it came back in the superficial reflexes, so it's okay. Please go past these. Yeah. Now, if you look at your bulk, did you notice that you had mentioned that the bulk of the upper limb and the right was less than that the left? Okay, that's a little, I mean, I know it's within reasonable limits. You have said just 1 centimeter difference, but that was a little unusual thing that stuck out because you're expecting it to be the opposite, and it's a very acute injury. In an acute injury, you're not going to immediately get such differences. And here somehow the right seems to be less, but it's only 1 centimeter. So maybe we could just think about that in terms of bulk measurement. The next slide, please. Yeah, you mentioned the tone. Yes, please go on. I'll just stop you and ask Dr. Prabhakar if he wants to add on something more because we are now going into the localization level. Dr. Prabhakar?
No, ma'am, we can go ahead, ma'am.
So the other thing is, based on all that is affected, you have localized it to CM. So can you give us each of these, for each of the muscles that you've mentioned, their myotomes? What is it, Akash?
Ma'am, abduction and supraspinatus, so So deltoid, I mean, deltoid and supraspinal abduction and adduction is able to do, ma'am. So maybe C5 and C6 I will tell too. And going to elbow, biceps, it's C5, C6, and brachioradialis will also be C5, C6. Triceps will be C7, if I have to say specifically. And wrist, he had a weakness, minimal weakness in doing flexor carpi radialis. And that also would be, I will localize to either C7 or C8T1, ma'am. But especially going to fingers, he had specific weakness. He had noted weakness, especially in the flexion and abduction. And so in such case, flexors and finger flexors and finger abductors, I will think of intraossei muscles. And in the abduction, I will think of intraossei muscle, and flexor digitorum profundus, I'll think of median nerve. So
Go ahead, Chris. Go ahead.
So in such cases, ma'am, I will think the weakness is over the level of C7 and C8. That what I thought of, ma'am.
Okay, go on to the next slide, please. And then, of course, it's a lower limb. Just go to the sensory, please. Yeah, reflexes we had discussed earlier. Yeah, go on. Because historically, you said that there was, sorry to interrupt. Historically, you said that the patient complained of below the chest, right?
Yes, ma'am.
So even below the chest sometimes can be specified a little better in historically, you know, when they say below the chest. In the arms, you were very clear. Forearm and arm, you mentioned that it was in the medial side. But here, as you said, if you're looking at landmarks on the chest wall, historically, what all can you choose? What are the landmarks that correlate with levels?
Level of nipple will be T4.
Sure.
And lower border of sternum will be T6. And umbilical level will be T10, and pubic symphysis will be T12.
So fair enough. So that in that sense, you've said no below T1. And historically, if it was possible, then it's okay to give a landmark below which he doesn't feel it, but in the way that the patient would have said it. So here, according to the sensory system, as you said, it was on the medial aspect of, historically, medial aspect of forearm and arm. And accordingly, you have said CNT1. Yeah. Vibration sense is preserved to thing, great. And which Dr. Anita had already mentioned. So when you look at this, what else can you say for you? She was talking about intramedullary and extramedullary. So how would you differentiate in terms of all of the sensations? She had asked, I'm just re-asking anything. What is the pattern for intramedullary versus extramedullary and sensory involvement?
So extramedullary, they will have an radicular pain. It will be like a compressive, can be a compressive lesion. So they will have a radicular pain. Meanwhile, intramedullary will be a funicular pain, but patient as per se, he had a severe back pain and had a post which he didn't mention any specific radicular pain.
Sure.
And
because it's acute onset, the history is a little different. We don't get all of that. And the pattern of weakness and sensory loss is how intra versus extramedullary? If it was a more chronic.
Usually
and basically ascending or descending, that which is
okay. So extramedullary, it will be an ascending, and on the other side, intramedullary, it will be an opposite of that one.
Because it's an acute event, we are not getting it in that way separately, because it is acute event. But we know it's traumatic, and as Dr. Krishna also mentioned, some of it is standard questions which we go through, and then you've also correlated your history with your examination. Just go to the next is your final.
May I just?
Yes, sir. Dr. Krishna, please go
ahead. Can you? So you said the patient was catheterized when the patient came to your hospital. Still, can you make out whether it's LMN or UMN by any method?
So maybe.
Please pass on if you don't know, so that we can move. Clamp the catheter and see. Just clamp the catheter and see. That's all. Very simple. Okay.
Okay.
Okay. One more I had in my mind. You just missed it. Okay, go on. When I remember, we can come to that. And also, yes, examination of the back of the patient, post-traumatic, very, very important. I suggest that you write it separately in general examination, because most of us think that the patient has only anterior. So just mention specifically there are no abrasions or lesions or anything, hematomas at the back of the patient. So you have turned the patient to one side and seen the back. That's very important in especially in trauma patients. And also, ideally, if you want to get a very good score, you can mention about the ENT examination, because all these areas can have bleeds, and sometimes in head injury you see CSF coming through the nose. So trauma, you should do a comprehensive physical examination, even though for us the neuro part is in question now. Okay, please go on.
Yes, sir.
Thank you, Dr. Krishna. Just go on to your next slide, please, Najan. Yeah, cerebellum. Then please go on to your diagnosis slide. Yes. So I think you've localized through history. We of course know that the etiology is traumatic. We have compressive, but I think in when you're saying it as compressive, you have given all your levels and localized it well. Any other comments from the others in the localization? Dr. Anita, Dr. Prabhakar, Dr. Ramya is also here.
Please, one or two questions.
Yes, sir.
What
Please
are the
go ahead.
causes of multiple levels in spinal diseases? Multiple levels are seen in standard MD question. Multiple levels, not single level.
In which diseases or with pathologies can you see multiple levels? Dr. Krishna is asking Akash.
Can we, if you can attempt it, please.
Multiple sclerosis, can we?
Oh, no.
No, with compressive myelopathies,
Yes.
will you get multiple levels is what sir is asking.
Multiple levels. Can I answer that?
Yes, please, sir. Please
Yes, sir.
go on.
Yeah, spinal arachnoiditis, multiple secondaries in the spine,
Fine.
and your case, trauma. At least 3. There are some more, I think. I don't remember now that offhand, but at least 3. Arachnoiditis, multiple secondaries in the spine, and trauma.
Okay.
Hello, can I?
Yes, please.
Dr. Danish, please go ahead.
Yeah. Just know I couldn't listen to your history and all, but the final diagnosis is traumatic compressive cervical myelopathy. No, this is a short duration. So why it can be a hyperextension central cord syndrome? Because the first symptoms will be the bladder, then no, it will. So central cord syndrome usually happens the central canal first. There is a history of trauma. So in acute case like this, August. So
Yes, sir.
it's only 2 weeks, no. So compressive myelopathy, we always give, no. It takes no months. Okay. So here now, why it can be a central cord syndrome?
Defend your diagnosis. Sir is asking why is it not a central cord syndrome?
So because especially in central cord syndrome, there will be sparing of dorsal columns and also lateral. Those columns will be preserved. But in our case, he has involvement of all loss of sensation of all modalities were there. So that's why.
So it is was there any hyperextension of the neck? Suppose it's there, no? The person can present with a whole cord can be involved if the damage is so. What are the other conditions where you get specifically central cord syndromes? Suppose the same patient comes with fever and similar picture. Have you heard of something called longitudinal transverse myelitis?
Yes, sir.
LETM?
Yes, sir.
Yeah. What are the other reasons for longitudinal transverse myelitis? Which common infection can present with LETM?
Herpes.
It's specifically it's scrub typhus. Okay, scrub typhus can present with transverse myelitis, which is longitudinal. Then even COVID.
Okay,
See, can you mention what is the posterolateral cord syndrome?
posterolateral cord syndrome, there will be involvement of lateral corticospinal tract and along with dorsal column involvement. Usually it will be,
Etiologies for that?
vitamin B12 deficiencies and vitamin E deficiency, copper deficiencies, and
There is hypocupremia and vitamin B12. Okay. Vitamin E, that usually presents with tropical ataxic neuropathy. What is okay? So, so in acute case, there's no traumatic compressive myelopathy you have, and no trauma. Is it a common site to have a C7 level, and all your levels are on the same? In trauma, is it common to have all motor, sensory, and all levels in the same level, or it will be little bit one above the other, something like that?
there will be sensory level. There
Yeah.
can be hyperasthesias and
Yeah, there will be different levels, no? So
yes, sir.
it need not be always C7. Okay.
Yes.
So did you examine the neck length? Is
Sir, actually,
neck? Ah.
yes, sir.
Okay, if there is C7, what specific pain you will ask the patient for? What is the very classical pain described for the C7 root? What is cervical angina syndrome?
No, sir, I don't know.
Okay, so you read the neck and pain section in Harrison where it's given. What is Sperling's test? Again, you should not do that for a C7 radicular pain. Okay, so it's multiple levels.
Sorry.
Multiple levels. No, you are discussing. There are so many other causes like multiple AV malformations, spinal arachnoid hemorrhage. Okay, then multiple.
Akash, what is Lermit sign?
Sorry, sir.
Lermit sign. Maybe my
Lermit sign.
pronunciation is slightly different.
Yeah.
Patient will have a sudden shock-like sensation, sir, radiating downwards.
Okay, good. And with your strong knowledge of anatomy, you correctly said intramedullary lesions will have early bladder, right?
Yes, sir.
Yes.
Yeah. Can you tell me an intramedullary lesion which is not so uncommon, which has late bladder?
Syringobulbar. Syrinx.
Intramedullary, but late bladder.
No, sir, I'm not sure.
That is syringomyelia. You know why it happens? Because in syringomyelia, the expanding syrinx does not damage the fibers; it will just stretch the fibers. So there is no early bladder, even though it is an intramedullary lesion. Okay, carry on, please.
Thanks, Dr. Krishna. And I think Akash kind of whispered syringomyelia at the very end.
Really,
So-
great. Akash,
Because I
you
think he
shouldn't
was
be in
very-
Akash. You should be on Earth.
Yes.
So-
Nice boy. He
so-
presented very well.
Thank you, sir. Thank you, Dr. Danish and Dr. Krishna. We have reached the time for the end of
Oh
the
yes.
clinic.
Oh yes.
So if I am so glad that everybody joined in and gave their wisdom because really needed. A lot of postgraduates are watching, and we also as teachers learn from each other. So I
Surely.
think thank you, Dr. Krishna, Dr. Danish, Dr. Anita,
Thank you.
especially, and Dr. Prabhakar for joining us from neurology. I think if it's okay, Dr. Dr. Prabhakar, any last things to add on?
Ma'am, it was a very useful discussion and it was almost like an exam style. So that way it is, the students will get a taste of what questions to expect in the
That's
exam and
That's true.
the importance of certain, especially examination and the order of examination. So nothing additional to add.
So thank you so much, Akash. I think you did have an exam literally, but you stood up to whatever was needed to be
Yes,
done. So
yes.
thank you for a good presentation.
Thank you, madam. Thank you,
sir.
Akash.
Thank you, Dr. Krishna. And Dr. Ramya, we'd like to hand back to Dr. Ramya right now, but I'd like to thank Dr. Ramya for initiating this series on with the CMC and the API, and Dr. Anita also for actively letting us take part in this. So thank you, everyone. I think we stop with the clinical presentation here. Is that correct?
Yes.
Thank you so much, ma'am, and thank you, Dr. Akash. You did an excellent presentation, and thank you, CMC team. So, any further questions, or otherwise we can end the session, ma'am?
No, we can end the session. Yeah.
Okay.
Thank
Yeah,
you.
okay. So it was an extensive and different experts as discussed. So it was a useful platform, and thank you, CMC team. And thank you, everyone. Exicon, you can end the session.
Thank you all.
Thank you. Thank you, sir.
Mr.